and welcome to In Conversation. This episode is another special edition of Intellect's regular podcast, brought to you in collaboration with Doctors Rupal, Shah and Jens Foell. Unfortunately, Jens can't be with us today, so Ru, it's over to you and me. Ru and Jens are, of course, the authors of Intellect's Fighting for the Soul of General Practice, The Algorithm Will See You Now. And today we'll be joined on the podcast by Minna Johansson and Victor Montori. So I'd like to welcome all three of you. Thank you for joining us on the podcast today.
Delighted to be here.
Great to be here, James.
Well, let me start perhaps by asking you, Victor. Can you just tell us a little bit about yourself? Can I get a brief introduction of your role, and also just tell us a bit about your research interests?
Sure, thank you. I'm Victor Montori. I'm a physician. I take care of patients with diabetes at the Mayo Clinic in Minnesota, the United States. I also have roles in a nonprofit organization called the Patient Revolution, where we try to advance careful and kind care for everyone. And I have a role in the Global Center for Sustainability in Healthcare, which is directed by Dr. Johansson. And I collaborate with her in research that supports the sustainability of healthcare globally.
Thank you, Victor. And Minna, can I just bring you in here as well? Can you just tell us a little bit about your role and what that might entail?
Yes, thank you. So I work as a general practitioner in a small town on the Swedish west coast. I've been working at the same healthcare center for 15 years, and I just love my work there. I also lead an international research network called the Global Center for Sustainable Healthcare, which Victor mentioned. And it's focused on that the way we currently practice medicine is not sustainable for patients, for healthcare personnel, for health systems, for societies, or the planet, and that we need a new appreciation of human, financial, and environmental resources in healthcare.
Well, thank you both for being here today, and it's going to be wonderful having your insights. Of course, Ru is here representing general practitioners and the NHS in the UK, so it'd be interesting to hear some of your insights on how that might be related to the current situation affecting the National Health Service and the current situation in the United Kingdom. So today I want to talk a little bit about measures. I know that's something that all three of you know quite a lot about. So Minna and Victor, perhaps I could ask you to explain a little bit about some of your work on measures, especially things relating to the clinician time needed to treat and those metrics that you might use around that, and how these might be used in the context of the United Kingdom, particularly when related to the quality and outcomes frameworks, which I know is quite popular amongst NHS practitioners.
Of course. So last year in 2023, we published a paper in the BMJ that argued that guidelines should consider the clinician time needed to treat. And the background for that is that, in my everyday in my work as a general practitioner, I feel like facing a tsunami of recommendations from guidelines and quality metrics without the possibility to follow more than a tiny fraction of them. There's a quite recent study from the US showing that GPs would have to work 27 hours every day to follow the guidelines that apply to our patients. And obviously that's not possible. There's no dancing if you need to work 27 hours a day. This massive gap between what is being recommended and expected of us and the time that we have to care for our patients, it has several negative consequences. First, it makes the care that we give inefficient because we don't spend our time on the issues of greatest importance for the patients or the interventions with the greatest benefit. It also makes care unequal because we don't spend our time on the patients with the greatest care needs, and it leads to ethical stress and burnout amongst us GPs and clinicians. So we propose this idea that guideline panels should estimate the time needed to treat the TNT of their recommendations. So basically, it's a very easy method to estimate what would happen if clinicians actually did what the guideline recommend them to do.
Yeah, Victor, over to you. Would you like to add to that, please?
Yeah, well, I think the Minna's insight into developing the TNT took the world by storm. I think I've been involved in a few papers that have had such an immediate and positive reaction, as if it had given a name to a problem that GPs, not just in the UK but everywhere, have been feeling, which is that the number of things they must do to provide, to offer good care, is expanding at a rate that is faster than the expanding time of the appointment, of the medical encounter, even after accounting, so that the expanded range of things is growing at a rate faster than the encounter time, even after accounting for continuity of care. The fact that you might be able to see the same person over time, because turns out that as those systems sort of try to optimize for access and try to accelerate the efficiency of the care, one of the things that they also suffer, in addition to this expanding array of things that must be completed, is the possibility that continuity might be enhanced. Add to that any little bit of disadvantage, and you have now delays in people being seen, so problems of access, uh, discontinuities of care, which means that you're almost always starting from scratch, and still the long list of things that Minna has talked about that demand a lot of time from GPs. So that creates a very disadvantageous situation for patients, a very disadvantageous situation for GPs or clinicians who are trying to do a good job. And as a savior comes in the algorithm, and so of course we humans cannot manage this, so we'll have technology take care of this. And just like with the industrial revolution, there is this hope that almost, I think, all of us know is not going to be realized, that any kind of automation that may come in will actually free up time for care. Rather, I think what we'll do is increase the opportunity for healthcare leaders and policymakers to argue, you have now all that technology support. Why can't you see people faster? Why can't you see more people? Why can't you increase the access? Why can't you improve the value? Why can't you improve the efficiency? So measures like TNT and work like what Minna is doing with increasing sustainability in healthcare, I think are coming in as a counterweight, as a rational counterweight to these exuberant expectations about what technology can do, which leave behind the importance of care as something that only humans can offer.
Oh, thank you both for those interesting contributions. Ru, I'd like to bring you in here as well. First of all, what were your feelings and thoughts when you first encountered this paper, and how indeed does it kind of interact with your own research and some of the examples that you've worked on?
Oh, it was like a light bulb moment. I loved reading it. I think what Victor said was true for me. And I thought, aha, this is such a useful way to frame it. I think the problem that we have in NHS General Practice with our quality and outcome framework, it's not that I think any of the targets are particularly wrong. It's just that the time needed to implement them all is really considerable. And it's how you kind of work out whether, the kind of benefits versus the harms, which Minna and Victor have both alluded to. We have others. It's not just the quality and outcomes framework. We have other prescribing schemes, incentive schemes, which come in from time to time. For example, one that we're currently kind of working on is a new liver pathway, which has been implemented in Southwest London. And it sounds great. There's a lot of engagement from GPs because the headline is, we must prevent deaths from liver cirrhosis. And of course, all of us would love to prevent deaths from liver cirrhosis. We have got no objection to that. But the pathway involves anyone with a first isolated ALT rise having a gamut of blood tests, which includes immunoglobulins, autoantibodies, HbA1c, lipids, a whole array of a full liver screen plus an ultrasound. You can imagine the number of abnormal results which come up incidentally, which aren't related to the liver. So I'm kind of interested to think about how this time needed to treat can be applied, because it's not just ordering the extra blood tests and the scan, it's actually dealing with the kind of incidentalomas that arise as a result of doing the tests. So I'd be really interested to hear what Victor and Minna have to say about that.
Yeah, Victor, Minna, over to you. Would either of you like to comment on that?
Well, I think it's what I experienced with this time needed to treat concept is that it's very efficient in communicating, because I think this is to a large degree about communication. We've been saying for so long time that when these like guidance comes from the organ specialists and it's impossible to follow them in primary care, we've been saying that, but it's very difficult to communicate. But when we have sort of a number that we put on it, it's easier for people to understand what we're talking about, which is in itself perhaps a bit complex and problematic. But anyway, it facilitates communication, I think. And I like, because like all of these guidelines, when you look at them in isolation, they might make sense. And where they are coming from, you can sort of see and understand where they're coming from. We all want better care for our patients. But the consequence of opportunity cost, the understanding of resources, both the time of clinicians and the time of patients as a finite resource that we need to be prioritizing carefully, we don't understand that concept. So we are actually, I think that in medicine, all the way from primary research to evidence synthesis to guideline development to quality metrics and to the individual consultations, we really suck at prioritizing, and that's hugely problematic. Yeah. I think what's happened during the last decades is this constant expansion of medical territory. We go to prevention for lower and lower risk populations, which means that we include larger and larger swaths of the general population. We also expand medical territory to behavior change, trying to change the lifestyle of each patient, one patient at a time within clinical practice, and now also to social prescribing. So we're trying to change, to increase social equity through individual interventions within healthcare. And that's also problematic because of the opportunity costs, because we don't have enough time to actually care for the people who are ill and need us the most. That's a consequence of this medical expansion.
And it's tough to argue against prevention because it's hammered in our head that, it's an ounce of prevention is better than a pound of cure and so forth. But the truth is that most of the clinical prevention that we do has minor effects, if any, and takes a ton of time to do properly. And it's much better done at the population level using public health interventions and public education and so forth. And of course, by improving social justice, which accounts for 15 years of lifespan improvement between the most disadvantaged and the least disadvantaged. And there's no medical intervention, preventive or curative, that will add an average of 15 years of life to a population. So we have to have, this idea of not only what less can I do for you, but also the idea that we have to be very humble in healthcare, that a lot of the action in improving health and lifespan is occurring outside or must occur outside in the sphere of policy, in the sphere of social justice. That needs to be reckoned with. And then leave healthcare, particularly to the possibility of dealing with illness and disease and improvements that come from appropriate use of and timely use of tests and treatments.
The liver example, you could wonder, like, if you want to prevent liver cirrhosis, if you would need all the money, if we would take all the money and time that we would spend on this new pathway and instead use it for community-oriented interventions to reduce the risk factors for liver cirrhosis, you wonder what the effect would be. What's the most effective way to prevent liver cirrhosis?
Thank you. And Rue, what about yourself? How do you feel about some of these comments? I know you're particularly interested in some of the ethical issues surrounding these issues.
Yeah, no, I really agree with what Minna and Victor say. I wonder what the absolute risk reduction is, what the numbers needed to treat are when you're trying to prevent liver cirrhosis in this way by investigating people with this isolated race ALT. And I don't know if Victor and Minna disagree, but I'm not sure how you can evidence this. It seems to make complete sense to take a public health kind of view on this and tax alcohol and processed foods, etc. Public education. But I'm interested that there's such a dominance of medicine in this that it kind of makes it difficult to have that conversation. It's something about the limits of medicine.
Well, and also the sense that GPs are just hanging out, in their office, wondering what else can I do with my time. And I have these patients sitting here. They're spending time with me. It seems like an opportunity for me to do more. But I'm yet to find the GP that actually says that. I don't know where they sit.
Are you sure? We're drinking coffee all the time and, roll our eyes.
Yeah, so much time.
But I wonder also, I think to understand this as a phenomenon, as a cultural shift that is happening, I think like this analogy of the public health river that we need to go upwards for prevention to behavior change to social equity instead of saving people that are drowning with clinical care. I think like from a public health perspective, that makes sense. But the problem is that we use the medical individualistic lens on moving upstream in the river. So like moving upstream is good, but it should be from the community. It should be community oriented interventions. Like we need to transfer back the responsibility for public health from clinical medicine to the public health arena.
I was just going to say, I see that Jens has joined us. It's great to have you. Thank you very much, Jens. We'd love to hear your take on this as well. Just please jump in.
Yeah, as a downstream rescuing physician, I think putting this task of upstream medicine in individual encounters and measuring cannot be right. I think about other areas, education, housing, jobs, where I think this is where these changes are made, but not in the individual closet with me. That is too that's too much, and I cannot do both at the same time. Disciplining, feeding, data generation, feeding the data monster everything I can. That's impossible.
So what support do you feel that you need, and what are the next steps? How can we improve this situation and scenario? Are there any practical realities we can affect?
I can add a little bit, and just riffing off what Jens just mentioned. The notion of individual or individualized, which is even more alluring prevention, is one that demands large volumes of data about human behavior, which then drives the business model of large tech that is expropriating people's behavioral information, not just when they're online, but when they're driving their smart cars or listening to their music or podcasts or books on their devices, when they're walking around and their devices are tracking their position, when they're using insurance products that offer discounts for safe driving, but what they're doing is tracking where people are going, and when they are paying with credit cards and other things. So people are being tracked and their behavioral information being used, and the business model supporting that is that behavior can be modified either through marketing for selling you things, or for the improvement of the population's health by intervening in each person now that we know all the challenges of your own behavior. And this is being offered back to payers of healthcare as a way of actually reducing costs. So there is an opportunity, which is not going to be here for too long, where we need to help people understand that giving up on their data and giving up on their privacy and giving up on this information in exchange for someone else they haven't selected, they haven't elected, and they cannot police, for to those people to manipulate their behavior, either to sell you product that makes you sick or to try or pretend to make you healthy. And we can see how alluring that will be for organizations whose responsibility is to improve health to actually pursue that. So this notion of prevention not only is affecting the clinical encounter, but also one of the ways out of the problem that Minna has highlighted is to transfer the responsibility for behavior change and for prevention outside of the healthcare system into a system of massive surveillance and behavior modification, which is also not, which is also kind of dystopic. So I think we have to come to terms with what prevention is, what it should be directed to, and make sure that we don't exceed what we should be doing with it.
Thank you, Victor. That's a very good point. And Minna, I'd just like to ask you for your final thoughts on this topic as well, please.
Well, maybe I have the responsibility to end this with a slightly more optimistic.
Thank you.
I mean, I share Victor's concern, of course, but I think, I still feel very optimistic. I think this is obviously an unsustainable system, and unsustainable systems tend to break. The pendulum will swing, I think, towards something more humane and authentic, and I don't know. Yeah, I think and more sustainable, more humanly and environmentally and financially sustainable. So I think I have great hope. I think there's a momentum to go to a better place in healthcare and in public health.
Thank you, Minna. And we just have a couple minutes left. Rui, if you have any final thoughts to share today.
No, I think before any new incentive schemes are introduced, I think we need to get used to having this conversation, and the clinician time needed to treat should be part of the decision-making process, I think, before we implement things. And also some kind of consideration about what causes the risk and where it's best targeted. So is that at a population level, kind of, upstream, as Minna was saying, or are we best placed to deal with it in practice, for example? I think that would just make it a lot more coherent.
Thank you very much. And Jens, there's just a very short amount of time left if you do have any final thoughts to add as well.
I think unpacking what should be done proactively, reactively in individualistic encounter is what needs to happen, and allowing the data entry people, us, more freedom in how to use the time. I like the idea of saying I have that amount of time, but hopefully reduce the amount of mad multitasking and being there for the patient and resolving the pressure on generating data in this area.
Well, thank you very much. I'd like to thank you all for your time today and for these insightful answers and comments. And just finally, can I just ask you, Minna, can you just tell us again the name of the paper that we used as a jump-off point for this topic today?
Yes, so it's called Guidelines Should Consider the Clinician Time Needed to Treat, and it's co-authored by me, by Victor, and by Gordon Guyatt.
Thank you very much. I urge everyone to take a look at that paper. Thank you all again for your time today. It's been a pleasure having you on the In Conversation podcast.